Good morning, everyone. Your Royal Highness, Princess Maha Shakri Sirindorn, Prince Mahidol Award laureates, Professor David Maybe and Professor Ralph F.W. Barton Schlager, Your Excellency Ban Ki-moon, distinguished guests, ladies and gentlemen, dear friends and colleagues. I am beyond honored to have been invited to speak at the Prince Mahidol Award Conference. Hosting this conference on universal health coverage in Thailand could not have been a better choice, given Thailand's leading and admirable achievements in implementing UHC. We are all here today making the effort and taking the time to keep on advocating and urging all governments all over the world to embark on the journey of universal health coverage. We are also here today because we reject the status quo that 70% of our children, brothers and sisters, especially from low middle income countries, perish needlessly from NCDs, including cancer, diseases that can be cured for the simple fact that they either live in the wrong place, the wrong time, be in a conflict zone, or have a bank account that is not immunized against catastrophic expenses. According to UHC's Global Monitoring Report of 2019, as we speak, nearly half of the Earth's population is still unable to access basic healthcare services, and 100 million people fall into poverty each year due to the heavy burden of medical expenses. And if current trends continue, up to 5 billion people will still be unable to access healthcare in 2030. Our health systems have long been geared to treat communicable diseases only, and certainly not to prevent diseases, making some to call ministries of health as far as ministries of disease. This has resulted in our current systems no longer being able to deal with the multitude of systemic shocks of today's epidemiological and current landscape. These shocks include the double burden of communicable and non-communicable diseases, as well as natural disasters, conflicts, mass migration, urbanization, and other so-called megatrends that impact the health system. That is why our health systems that we have all inherited are literally bursting at the seams and have become fragmented, inefficient, and therefore defaulting on delivering life-saving treatment to their citizens. To really understand the value of universal health coverage, UHC, is to imagine its absence. To imagine for 1 second what it looks and feels like if you or a loved one who is struck with cancer, for example, is not covered for treatment nor protected by UHC. It's like looking at someone and saying, the magic potion that will save your life is here, but I'm so sorry, it's not for you. This is what lack of UHC and access to treatment is all about. We can sugarcoat it all we want, but it is about the harsh and tragic reality of depriving someone from life-saving treatment. The hopeful news is that we now have a new drive from the UN General Assembly through the Political Declaration on Universal Health Coverage, urging countries to implement UHC to all persons, whoever and wherever they are and whatever their income level, so that they are guaranteed an essential package of quality health services without having to incur catastrophic expenses. UHC is about not leaving anyone behind. UHC does promise a lot. At first glance, one would be forgiven if one dismissed it as perhaps yet another idealistic rhetoric. It could sound like an impossible utopian dream to many countries. However, I assure you that the UHC ambition is absolutely not a dream. I have attended the 2019 UN high-level meeting in New York and became more hopeful as I heard many leaders from Rwanda, Turkey, Thailand, Philippines, Uruguay, Zambia, and others who have embarked on implementing UHC. We all know the benefits of implementing a universal UHC that truly leaves no one behind. A lot of emphasis was on that, but not on the how to do that. There are main important prerequisites and contextual drivers that have to underpin the approach prior to embarking on UHC. All equally important. Rifat Atun article on Turkey's health transformation in The Lancet highlighted many of the below. Firstly, without question, you need political will from heads of government and across the whole cabinet. Dr. Tedros, the DG of WHO, said in his opening speech, health is a political choice, and he was glad that many leaders have made that responsible choice. That is why those who have implemented UHC in their own countries made sure that the decision was a whole cabinet responsibility and a long-term goal. This ensured that the cabinet was committed not just to the concept of health for all, but all for health. Secondly, the overall thinking has to be one of comprehensiveness and of transformation. The usual transient Band-Aid solutions no longer work and have become actually extremely wasteful and inefficient. Therefore, countries have to take a new, fresh look at their health and health financing systems to re-transform and reorganize to meet the epidemiological needs of today on a life course approach, making sure to strengthen their primary healthcare system as a cornerstone of their efforts. Thailand, of course, is a great example of its primary healthcare strengthening work since the 1970s that laid the strong foundation upon which they were able to expand their UHC. The third prerequisite, there has to be a decision as to the managerial structure and engine that will drive the process forward in a terrain that is long-term and fraught with many obstacles along the way. The countries that are delivering UHC understand the limitations of their current capacities at their health ministries, which do not typically include a team of long-term strategic planners. Health ministries' roles in many countries end up being more operational rather than being able to focus on long-term strategic and policy changes needed to improve health nationally. Once a minister is appointed, he or she enters the treadmill cycle of barely managing his or her schedule. So those who have a long-term vision for UHC have established a transformation team, like the model in Turkey, or a policy entrepreneur team, like in Thailand, or the planning commission team in India. Strong governance mechanisms such as those are crucial, as the planning and implementation stage can take from 2 to 5 years and above, certainly exceeding any political cycle of any minister. The transformation team is the only way to make sure that the cabinet commitment is sustained for the duration of the journey to achieve UHC and beyond, to its monitoring and evaluation. Fourthly, but certainly not lastly, the people. The people. UHC is about giving healthcare access to the people they intend to serve. Persons healthy or unwell have to be at the center of it all. In many countries, people have long lost trust in their public health system. Gaining the trust of the people is crucial, and they have to be part and parcel of the UHC plan from the beginning. Starting from enshrining and delineating their rights, their health rights in the laws, making sure that all understand it is a right and not a gift that can be given or taken at will. Delineating those rights into what to expect from a health system in terms of respect, quality, delivering an essential package of services, procedures, and transparent channels for public complaints will offer you a large, powerful constituency that adds to a country's monitoring and evaluation function of those services. By so doing, empowering patient rights to a whole new level and transforming healthcare systems from ones that are designed around diseases to ones that are designed for people. And the fifth item, the usual elephant in the room, who will foot the bill? Who will foot the bill? UHC is not a one-size-fits-all, but many countries will tell you that significant money came from simply reducing existing inefficiencies. Some from an increase in actual investment as a percentage of GDP. And of course, some from co-contributions from the public. Others utilized innovative financing, including earmarking what I call the good taxes. There is such a thing called the good taxes, by the way, to finance some of the services, such as taxes on tobacco, alcohol, sugar, and salt, as the drivers of many non-communicable diseases. These provide triple wins. One, it reduces the avalanche of new NCD and cancer cases. Two, saves future treatment costs, and at the same time provides new revenues for the budget for health and well-being. How great is that? Starting with fighting tobacco, that alone can reduce 1/3 of all cancers and other NCDs. Countries who have understood the power of taxation on harmful products benefit greatly. A great example is the Philippines, who placed a so-called cancer tax on alcohol and tobacco. What a great name, by the way, cancer tax. The revenue generated from that is now in part being used to pay for universal health coverage for the citizens of the Philippines and for new health programs. Other powerful examples include vaccinating girls and boys with the cervical vaccine, the hepatitis vaccine, and others to literally stop those diseases in their tracks and save lives and save money. Other innovative financing includes a new study by Vital Strategies, a global organization that urges governments to reconsider giving subsidies to unhealthy commodities that harm us and cause NCDs, such as fossil fuels, and redirecting those subsidies toward health provision or other social benefits instead. Again, another win-win situation. The opportunity for further efficiency savings can also be addressed by the proper governance and use of the latest digital innovation, such as point-of-care diagnostics, digital health, artificial intelligence, to name a few. So, my dear friends, the money can be found if the will is there. The money can be found. Footing the bill for the current disease burden is one thing. But to keep on footing the bill for recurrent, preventable, and early detectable diseases is downright irresponsible and wasteful, both in human terms and money terms. The global health community has already proven that by investing $1.7 per person per year on prevention and early detection on NCDs saves countries in treatment costs $350 billion cumulatively by 2030. $350 billion. Amazing. We have also known for a long time what to do to curb those NCDs at the instance by implementing effective regulation, legislation, and taxation on commercial determinants of health. And yet, many UHC packages to date still shy away from including coverage for prevention and early detection for those very diseases such as cancer and other NCDs that inflict the highest long-term burden on health systems financially and administratively. Mind-boggling. Leaders and countries who have really succeeded in implementing meaningful UHC understood that cancer represented the ultimate litmus test for universal health coverage. They understood that by excluding cancer in their UHC plans, the plan would be rendered as hollow, meaningless, and so porous that it would leak out all all the economic investment put in beforehand. A great example of this would be cervical cancer. Global donors such as the Global Fund, who supported low middle-income countries burdened with AIDS with millions of dollars to help beat the disease. Whilst we are thankful for that, we also know that HIV patients are more likely to have cervical cancer as well as other comorbidities. So if UHC plans do not include cancer, then all this investment in saving lives collapses and dies with the very patients themselves afflicted with cervical cancer. So UHC is not just about investing more, but investing better. It is about investing better. I strongly urge all countries to start the UHC journey because, as aptly coined by Honorable Professor Sakol Sataya Dorn, former Minister of Health of Thailand, the decision to embark on the UHC journey is not because you are a rich country, but precisely because you are a poor country. Thank you very much.